Welcome to today's presentation, Assessment of Pediatric Patients, presented by AnMed Health. The purpose of this presentation is to prepare you for your upcoming pediatric surgical patients and hopefully to alleviate some of your fears. Today's objectives are to discuss age-appropriate assessment of infants, toddlers, preschool, school-age children, and adolescents, review normal vital sign parameters for the pediatric patient, and to discuss post-op assessment for the pediatric ENT patients, which is what we understand will be primarily your pediatric surgical population. It is important to remember that pediatric patients are not just smaller adults. Their heads, primarily the infants and toddlers, the heads are proportionately larger than the body. They have higher, faster metabolism. A small body means weight-based dosing. So for your pharmaceuticals, you do not use an age dose. You use weight-based. Infants and toddlers have immature temperature regulation, as well as some of the pediatrics. They have greater percentage of body water content and greater insensible water loss. And remember, most important, children will look very normal when they present, and they will maintain normal vital signs until they suddenly fall off the cliff. You may be more accustomed to your adult population where you have gradual decline of vital signs and a little more time to prepare and see things coming, but children do not present that way. It is a rapid decline of vital signs, so pay very close attention. As you assess your pediatric population, make sure it's age appropriate. Try to determine the developmental level of the child. Introduce yourself to the parent first and then the child. Start with least invasive tasks first, such as asking the child questions if they're at that age, determine their level of consciousness and responsiveness. Move on to more invasive tasks later, such as checking a blood pressure, temperature. Position yourself at the child's eye level. Make contact and call the child by name. Talk quietly. Be specific and positive. If you're going to do a procedure that is going to hurt, be honest. Use concrete terms. Offer choices when appropriate. For example, would you like for me to check your blood pressure first, or may I listen here to your lungs? Honesty is vital to establishing a trusting relationship with children, especially with older children. Be honest, especially the older children. They're going to remember, and they will call you out on it. For your infant assessment, when the child is quiet, try to listen to the heart and lungs. This is the best time to capture accurate sounds for those. We often find it's best to examine an infant when they're in their parent's lap. It also allows for positioning over the parent's shoulder to, listen to the back better for your lung sounds, or the anterior for heart. When you count the respiratory rate for infants, this needs to be done with a stethoscope for a full minute, not by visual inspection as you would do with an adult. Involve your parents. Remember, stethoscopes tend to have a metal frame on the ball or the bell, so as you listen to a child, especially using bare skin, you'll want to warm your stethoscope so as to not shock them. Use a soft, gentle voice, and where you can, use distraction techniques. We often, for children who use a pacifier, will often dip the pacifier in sugar water to help distract, especially when we're going to do some painful procedures, and it tends to help a lot. For your assessment of toddlers, now this is no easy task at first. Generally, they're not going to be receptive to you just coming in the room and touching them first thing. It's often best to try to use some of their security objects they may already have in the room to make them feel comfortable, such as a teddy bear or a security blanket. You can demonstrate with their teddy bear, let me listen to Teddy's lungs, and then the child will tend to be more receptive. Examining the child while they're in the parent's lap or where they're standing near the parent also helps the process. The child will be curious about your equipment, your stethoscope. Let them examine it. Let them listen to their teddy bear's lungs. Inspect body parts through using play games. Let's count your fingers. Let's count that. Let's count your toes. Look for bunnies, whatever works. Counting games tend to make the toddler population more receptive. Involve the parents wherever possible. If the child is uncooperative, you need to proceed with your task quickly as possible. And always, children love praise, so be sure to praise the toddler population. Even if the child has not been the most cooperative, you need to find a way to implement some praise, because in turn, children will become more cooperative as they feel they're being praised and rewarded. Now with this, you need to remember, as a child returns back from anesthesia, the anesthesia may make them drowsy, and it may go completely the other way. And often the child will be very uncooperative, bouncing off the walls, very hyper. At this point, you're going to have to prepare the parents and let them know this reaction is normal. Parents will often say, "What's wrong? What's the matter with my child? My child does not act this way. What's going on?" And they'll be very concerned, and you're going to have to comfort them and make sure they understand that it is just an effect of the anesthesia, and it will wear off shortly. And at this point in the process, you're primarily taking care of the parents, the grandparents, and the visitors in the room, as they're very anxious about the way the child is acting as they're bouncing off the walls post-surgery. Now for the preschool age population. Generally, they do like to please. Generally, they're more cooperative than the toddler age, and like all children, they also love praise. So be sure to give plenty of encouragement and praise. When you offer choices, if possible, do not ever give a choice that you don't want the child to pick, because undoubtedly they're going to pick that choice. Explain tasks in very simple terms. Again, these children will also be very curious about your equipment, and they're likely going to want to touch it, same as the toddler population. Let them do that. You can clean it afterwards. They also understand, they're also very visual learners, so demonstrate your tasks, what you're going to do with your equipment on a toy, a doll, or even the parent. Demonstrating on the parent is often very helpful, as the child sees the parent was not hurt by the task. Avoid using words like take, cut, broken, or put you to sleep. Remember, children generally do not like naps, and they don't want to be put to sleep either. And all of these words sound very hurtful. And although some of the tasks you're going to do will hurt the child, there's better ways of wording it that the child will receive better. Say we're going to have to do a little ouchie here, or a little bee sting. Often for our pediatric patients, we'll let them know that we're going to have to do a big ouchie, and we'll count to 3, and together, when we get to 3, we scream, start the IV, and the child usually does not know it's happened, because at the count of 3, they're so busy screaming with us. For your assessment of the school-age child, speak very directly to the child. Explain exactly what you're doing and why. Take time to listen. These children will know at this age that something's going to happen, and it may hurt, and they're going to be a little more skittish. So quite often they're going to come up with little tactics like, I've got to use the bathroom, I need some water, I need to go do this, to try and get out of it. And although they're not going to get out of it, taking the time to listen to them often helps. Children of this age are generally more curious about their body functions, so take the time to teach them about these. And as always, be very respectful of their privacy and dignity. For the assessment of the adolescent teen population, privacy here is a must. Confidentiality as well. Make all efforts to avoid unnecessary exposure. Pull the curtain, shut the door. They want to be kept private at this age, and you need to respect that. Teach them about normal physical development. Encourage the teens to discuss concerns, and take the time to listen to those and respond. Be sure you facilitate a non-judgmental environment, which will encourage the teens to talk to you. Facilitate visits with their friends, their peers, grandma, grandpa, when possible. So now we'll proceed on discussing normal values for children. So here we have normal blood pressure vital signs for birth, depending on weight, for the neonate at 96 hours, for the infant at 6 months, the toddler, the school age, and the adolescent. You may want to print these. Keep the normal values handy in your pocket. You do need to be very aware of what a normal range would be per child, although it can vary somewhat. What you need to pay attention to is blood pressure values when they're sleeping, when they're awake hurting, when they're screaming, when they're crying. You're going to expect the blood pressure to rise during these situations. Now, if you notice a sudden jump in a blood pressure for any of these ages while they're asleep, then there's something else going on you're going to need to look into. Are we having a fever? Is the child in pain? Vital signs continued for the heart rate. Again, you'll see the neonate awake blood pressure, 100 to 180, versus asleep, 80 to 160. Then we have the infant awake, 100 to 160, versus asleep, 75 to 160. And on down you can see the toddler, preschool, school age, and adolescent. Now it's important for you to remember these normals so you can know when something's out of range. It's very often when a neonate, or it's not uncommon when a neonate is crying, screaming like crazy in a full fit, to see a heart rate jump up to 180 easily. So when the heart rate goes that exceptionally high, you should be ready and keep watching. When the child calms down from crying, that rate should drop back down to a normal range. And other things you need to consider, obviously, are very low heart rates for any of these populations. If those don't pretty soon come back up to a normal value, you've got to have an issue to manage. And our vital signs for respiratory rate. Again, infants, generally lower than the toddlers, preschool age, school age, adolescents. As the age goes up, the respiratory rate decreases. Now, as we mentioned earlier with the infants, you need to listen with a stethoscope for the respiratory rate instead of counting, because infants often do little guppy, fast, panting breaths, and then they'll slow down again within a minute's time. Therefore, you've got to count it for an entire minute to get an accurate count. Abnormal vital signs for any of the pediatric range would be obviously tachypnea, tachycardia, lethargic babies. They are not just sleeping. Something else is going on, so pay close attention to whether or not you can rouse the child. Toddlers. A strong alert that something is wrong with the toddler is if they're not afraid of you, as you are a stranger entering the room. This is not normal behavior. Be sure to listen to the parent. Always take the time to ask the parent, is this the child's normal color? Does the child normally make this noise when they're sleeping? Is this the child's normal behavior? The child's parents is the, first stopgap to noticing something is out of the norm. So pay close attention to what the parents have to say. Weight-based therapies for the pediatric population. Particular to children is the need to calculate all these therapies for each child individually. Per weight, not age. The Broslau tape relates a child's height as measured by the tape to his or her weight. To provide the medical team instructions, including medication dosage, the size of the equipment that should be used, and the level of shock voltage when using a defibrillator. So be sure with your clinical documentation. The weight of the child is always readily available for any emergency situation that may arise. And here's the pediatric assessment triangle. So when you prepare to assess a pediatric, these are the key points you should evaluate for. The overall general appearance, the circulation to the skin, and the work of breathing. For all of the pediatric patients, a general assessment should include a head-to-toe assessment, neurologic, your level of consciousness, speech, swallowing, gaze, motor movement to all extremities, respiratory, the pattern, the breath sounds, pulse ox, your cardiac assessment, the rate, the rhythm, capillary refill, circulation to all extremities, color and temperature, nail bed color hands and feet, pulses, edema. Gastrointestinal, where you listen to the abdomen, bowel sounds, and stool. Your genitourinary assessment. you'll document the urine output, quantity, color. Musculoskeletal, check for motion in all extremities. Skin assessment, again, the color, the texture, alterations. Psychosocial, the mood, the behavior of the child. For pain assessment for the pediatric population, for children 2 months to 7 years, we often use the FLAX scale. This basis provides scoring for 5 different categories: face, legs, activity, cry, and consolability. Another pain assessment is the NRS, Numerical Pain Rating Scale, used for patients over 9 years old who are able to verbalize, of course, their pain level on a scale of 10, with 0 being no pain and 10 being the worst pain you can possibly imagine. How much do you hurt right now? And again, that numeric value would be for age-appropriate children. Another consideration would be the Wong-Baker faces. Pain rating scale. And younger children can often point to the face that most resembles their pain level. But again, this takes some level of discretion in deciphering, because some children are just unhappy about being there, and so they're just going to be inclined to pick the ugly face. The NIPS pain assessment scale, neonatal infant plan scale, is recommended for infants less than 1 year old. Again, you're going to assess several different values to determine a pain score amount: facial expression, crying, breathing pattern, arms, legs, and state of arousal. The post-op assessment, again, should be another head-to-toe assessment, assessing neurological status, and of course many of them are either going to be bouncing off the walls or be sleepy, but you need to monitor and document and assess for changes in that over time. The anesthesia should begin to wear off. Respiratory, of course, counting your respiratory rate to be sure it is not too low, they're not too sedated. Cardiac, your blood pressure, your heart rate. Gastrointestinal, genitourinary, musculoskeletal, how are they responding, moving, controlling their bodily limbs. Skin, and psychosocial. And again, for your respiratory, it is common to leave a SAT monitor on these pediatric children, so even when they're falling asleep in between drowsy periods, you can keep a close eye on this. In the post-op assessment, please be sure to look for loose teeth. And the younger toddler, younger school-age children age, it's a tendency for them to have loose teeth anyway. And, the procedure may further loosen some teeth, and they may lose some, so be sure to check for that. Try to get the child to spit out secretions. Post-op ENT surgeries, honestly, their throat's going to hurt, they're not going to want to swallow, and they're going to let secretions pile up in their mouth. Try to encourage them to spit that out. Maybe use a bulb syringe to get it out. Try to get the parents to help with the bulb syringe. Try to encourage drinking. They're not going to want to because the throat's going to hurt, but you need to encourage it. And also post-op, they're going to come out generally with an IV fluid. And this is going to be another issue for you to maintain and watch out for, especially for the hyper children, so you keep a close eye on your IV site. Be sure with these pediatric patients to give the pain medicine routinely. They may not always know how to vocalize that they're hurting until it's too late and they're in tears. Give it routinely. Pay attention. If it's ordered every 4 hours, you need to be probably giving it every 4 hours. Especially pay attention to the first dose of the morning before they arise. Try and go ahead and give them a dose before they get good and awake and pain medicine starts wearing off, so they won't be so miserable. Encourage family to give liquids frequently. Again, post-op, this is not going to be fun, especially the next day. They're not going to want to swallow. But you and the family both have to encourage this, and sometimes you even have to get creative. Maybe the family can buy the child a new special cup to drink out of, something of that nature. Try not to give red foods or red drinks, and we also try to stay away from purple because those colors tend to look the same way. Remind the family and visitors of this, as they may incidentally bring in some red juices or foods, and this in turn can end up looking like blood, so this is why we want to stay away from this red coloring or purple coloring. Elevate the head of the bed at least 30 degrees, and be sure to watch for excessive swallowing and excessive bleeding. Be sure to keep watching and monitoring and documenting for the sedation level. Again, that should be wearing off with the anesthesia over time. And also you want to monitor the sedation level as you're giving pain medications. Watch the vital signs, decrease or increase blood pressure, pulse. Listen for stridor. It's not too uncommon to hear this in the children post-op. Watch the O2 sat and also asleep when possible. Voiding, make sure the child is getting enough fluid intake that they are avoiding at least 3 voids in 24 hours. Pay attention to central and peripheral pulse quality. Is it absent? Is it weak? Is it bounding? Skin color, pay attention to that. It's not too uncommon for the pediatric population to return from surgery somewhat pale, but they should start pinking up pretty quickly. Watch temperature for any fever spikes and their moisture level. Pay attention to capillary refill and the patency of the IVs. Education of parents is very important. If you do not properly educate the parents about what to expect with their child post-op, they're most likely going to be presenting back at the emergency room or the doctor's office. Be sure they understand to watch for a fever over 102.5. It is pretty common to have a low-grade fever the first few days after surgery, but not in excess of 102.5. Please encourage the fluids. The child's not going to want to drink because it's going to hurt. The parents have got to understand the importance to this. Keeping them hydrated, of course, will help this with the fever. The parents need to understand if the fever persists or goes too high, they must contact the doctor. Often children are sent home with something to control nausea, such as Zofran. Make sure the parents understand it's okay to give them this. This is what it's prescribed for. Again, parents need to understand the importance of not allowing their child to refuse to drink. They've got to find a way to keep them hydrated. However, if the child will not and they cannot overcome this and they suspect their child is getting dehydrated, they're going to have to contact the doctor. They also need to understand to watch for bright red bleeding from the mouth or nose, and those signs should be reported to the doctor immediately. Again, with the education of the parents. Let the parents know that post-op their child may be fighting and screaming because of the anesthesia. You're going to have to console the parent and let them know this is normal. Parents have to understand about their role in encouraging fluids and giving pain medicines routinely so the child will not let the pain level get ahead of them to where they're in excruciating misery. Again, the patient education, the parent education is vital to keeping the patient from returning with dehydration. Soft diet is recommended. Eventually the child is going to want to eat and drink, and the parents need to understand soft diet. Popsicles, Jell-O, ice cream. Post-op there's going to be some scabbing in the throat. And, 7 to 10 days, those scabs in the throat are going to start falling off. So hard food such as chips or any other thing that could scratch up the throat is not recommended. Parents need to understand to only give the child pain medicine that has been prescribed, not to add anything to it, and certainly not to give aspirin, as that increases the risk for bleeding. Parents should understand that the child may have bad breath. That's pretty common for 10 to 14 days following the procedure. And also with the pain medicine, constipation may be noted for several days. Some parents will actually look in their child's mouth, not too uncommon, and they're going to see 2 whitish areas where the tonsils used to be. They need to understand this is normal and not a sign of infection. And for some of the other ENT surgeries, such as getting tubes put in the ear, children will often come back from surgery with cotton balls in the ear. If so, let the cotton ball fall on their own. But you're going to find many children, toddlers, they're going to go ahead and pull at those. Most often, for your post-op care of these, you will be putting drops in the child's ear. Other surgeries you may see will be the peritonsillar abscesses. And in these cases, these children are going to be on IV antibiotics, which you will be managing and maintaining your IV site. And again, remember, children are not just little adults, so be aware and be diligent in your care of them. And as you encounter tricky situations in your pediatric population, you're just not sure, you need some additional reinforcement, feel free to call the AnMed pediatric floor anytime, day or night. We'll be glad to give you some guidance. And for the emergency room setting, primarily for your pediatric post-op patients, the biggest reason for return or for a visit to the ER is going to be dehydration. In some post-op instructions for some physicians, they have a particular magic intake number, and so when the parents receive a post-op call from the physician's office, the physician already has a designated magic number, and so they'll ask the parent, has your child drank 12 ounces of fluid? And if the parent says no, they're going to be instructed to seek additional care. In this case, they may show up at your ER. So dehydration is significant. Often the parents are going to say, well, little Johnny doesn't want to drink. I can't get him to drink. And little Johnny won't take his pain medicine. In these cases, you're going to have to remind the parent who's in control and, that they have to ensure this happens. And, the general standard magic number is for measuring for enough fluid intake would be 3 wet diapers a day or 3 PP events to the bathroom. Another important reminder for the parents is to watch the child for vomiting, and this can even happen at 7 to 10 days out post-op. This is why we ward them or caution them against using red or purple foods or drinks, because this vomiting can even occur 7 to 10 days post-op, and when the child vomits, you need to be able to determine the color to determine if there's any blood there. For some children, the younger ones, they may not actually vomit, but they keep holding it in their mouth. And you can notice for signs of vomiting with excessive swallowing when they're sitting watching TV. So make sure your parents are educated about this. And for the cases where the post-op bleeding is present, and it's not that uncommon, it's a significant case and the child needs to be seen immediately if it's a call-in. If they're in the emergency room, they're going to be staying because they're going to be returning to surgery, and quite often the physician will take them to surgery and cauterize it to stop the bleeding. Thank you for attending today's presentation.